Hola, buenas tardes a todos. Vamos a empezar la sesión plenaria de vascular con ponentes de muchísimo nivel. Y el primero de todos lo voy a presentar brevemente, René Chapot. René Chapot is, I think, one of the most renowned endovascular radiologists nowadays, head of the Neuroradiology and Endovascular Therapy department in Essen, Germany. He is, I think, neurology also with a long research experience. He will talk about a very important topic, a very key topic, not only for the future, for the present of the treatment of aneurysm pathology, the flow diverters. So also all the speakers, please remember that the time is limited to 15 minutes. We have to adjust to the schedule that is very tight, you know that. And please, Dr. Chapot, you can start with your talk.
Okay, hello, nice to be on board. So let's go with flow diverters. I mean, flow diverters are great, but they have also problems. And I think that it's important to try to have a balanced opinion. So the reason why a lot of people use flow diverters is because when you have such kind of very large aneurysm, which is definitely a challenge, it's possible to treat it, and to first year there was stenosis, to dilate the stenosis, to put the flow diverter. It's not so easy. Sometimes it may be, sometimes it's not. And you see that here there's almost no flow to the aneurysm, and the important is some follow-up where you see that there is no flow, and the most important that the aneurysm is gone. So this is the goal to be achieved. The question is it always possible or not? And the answer will be not always. So a lot of people use and potentially overuse because it's the best endovascular tool today. It's easy. It offers, compared to coils, to stent coils, to webs, to any other devices that exist, it's the best way to achieve a stable result. If we look at the results of meta-analysis, this figure is given out. I don't know what it means. Meta-analysis is putting apples and bananas and everything together and then to say it has no taste. And for me, this has no taste, and this means very little things. Pedro Lilik just presented his series. Pedro belongs to the very enthusiast in using flow diverters, 1,000 aneurysm, a huge number, and 96% occlusion in 5 years, a very low morbid mortality. I mean, these are the ideal results. And I'm not sure that they express all the concerns that may be seen, because if you have here the best results, you have also results that are the worst results. And the worst results are done by persons that tried to make a randomized trial, that made a FIA trial that was stopped because of too poor results. So Jean Raymond is known to have a lot of concerns about this. And he compared flow diversion versus coiling or parent artery occlusion or best possible treatment. And after, so there was a registry and a trial, and all this was stopped after around 100 patients because mortality and morbidity in all both 16% was too high. And you have also other persons that are, how should I say, not believers, but believes means it's a religion, and should not be a religion but a medical tool. And for instance, Emmanuel Houdard is arguing severely against flow diverters since several years. And when he presented his series on parent artery occlusion, the results, of course, in aneurysms that can be treated this way, large giant fusiform aneurysm of the ICA, not, of course, a posterior circulation, all treated by parent artery occlusion, almost no complications, and great results. So definitely he has a very different opinion. So how can it be that opinions vary so much? Probably because the tool has been designed for large and giant aneurysms, but it's mostly used in small and medium-sized aneurysms. And those aneurysms here are easy to treat and there are no problems. So what are the potential problems? And I'm going to show all the concerns that may be seen. So it's a concentrated of bad things, which is not reality. Reality is also the good things. But I think that usually we mostly see the good things. So missing shrinkage, this is here a serpentine aneurysm, meaning that the whole M1 segment up to this point here, where I don't know what it's anymore, is something in between a clot. So you can flow divert, it looks good, but what is the meaning of this? After 6 months, there still is a bit of flow, and the bit of flow hides the problem, which is a huge growth of the aneurysm. So a very poor indication, or in my opinion, situation where it should not be done, are serpentine aneurysms. Other problems that may occur is an acute thrombosis of a non-thrombosed aneurysms. And now we're going to look at the worst situation, those aneurysms here of the basilar tip extending posteriorly in the mesencephalon are the worst to treat. And I don't know any method or any technique or anyone that has a good series with good results, whatever open or endo surgery. Here is the result. So we put a lot of material inside, we put flow diverter, and it was almost good, but almost means there was some edema because of the acute thrombosis, and so edema and swelling of the brainstem with major clinical consequences. So it does not work either. Some aneurysms may bleed. So literature says 1%. When you don't know how frequent it is and it's quite rare, it's always 1%. I think that if you're facing a giant unthrombosed aneurysm, the risk of those aneurysms to bleed is much higher. And the small aneurysm or the same aneurysm being partially thrombosed, this will not bleed. And we've been treating numerous of those patients partially thrombosed without problems, but when they're not thrombosed, it's definitely different. Here it seemed after 4 days to be good, and 2 weeks later she bled and she passed over. Side branches. How much are side branches a problem? Surprisingly, not so often. And this here is a patient where several things have been done for this basilar aneurysm, and despite all, you see stents, coils, and still growing. You see here that there is an active clot, which is at the most unfavorable position, so that here further flow diverters were being placed, and you see here the anterior spinal, and after a couple of flow diverters, it's gone. And simultaneously, this patient had severe bradycardia, and the spinal artery was not visible anymore. And I cannot explain it differently, this severe bradycardia, by the fact that there was no collateralization. So I was not aware that the occlusion here of the spinal artery could lead to this. I mean, we know all kinds of problems that may occur, but not this. At least I had to take the stents out. And when I took the stent out, the artery was immediately there again, and the bradycardia was gone. So side branches may occur. In fact, it's quite rare. It's much more frequent, not in this situation, but for MCAs. And this is here a patient with an MCA where aneurysm, some artery already gone here, and flow diversion was achieved. It's partially thrombosed, and it was quite okay. The procedure, flow diverter was placed. I did not pay enough attention that here was a small division, so that I brought the flow diverter in one of 2 branches, and you may see the difference between after and before. This one here is gone, this one here. And well, at some point, increasing the blood pressure, something may help. He did not have a complete infarction here. He had some DWI lesions, not too much, but obviously problem was flow diverter was too distal, so they've been kept beyond this bifurcation that you see here. And it showed that in bifurcation aneurysms where arteries are of the same size, using a flow diverter is probably not a good tool. So the larger the artery bridged by the flow diverter, the higher the risk of occlusion. The small ones, the perforator, I mean, I showed you one spinal artery, it's the only one. All other perforators, all M1 lenticulostriates, they don't occlude, but the large, I mean, the bifurcation arteries are more of a problem. Other things that we cannot control and which may be an issue is the kinetics of thrombosis. In case of acute thrombosis, there may be much more ischemia than if progressive thrombosis occur. And this is something that we cannot really act on, maybe increasing the level of antiaggregants, but this has other drawbacks. So flow diverter in MCA aneurysms, no. My answer is definitely no. Or some alternatives, and in situation, even after clipping, you may see the clip here, aneurysms may recur, and this one are treated with a kissing flow diversion. And interestingly, this was immediately after. You see 3 years later, the bifurcation has been somehow zipped more proximal because now the bifurcation is here. Quite interesting results. Okay, issues, dual antiplatelet therapy. It's not possible today to bring in a flow diverter without giving antiplatelets. Which antiplatelets to give? Usually a combination of aspirin and P2Y12 inhibitors. So this is a glycoprotein that is in the thrombosis reaction chain and which is suppressed by clopidogrel, prasugrel, or ticagrelor. Problem of clopidogrel, it has about 20% resistance, and this was responsible in the 10 years ago, first times of flow diversion for significant amount of complications. Prasugrel and ticagrelor are more efficient, but have problems too, because if they're too efficient, then something like this may happen. So the answer is unclear. Everybody has his own recipe and claims that the recipe is a good one, but how to be sure that this is a good one? Probably we're moving into the direction of platelet function testing to check whether patient is either responder or non-responder. This is for clopidogrel, or if more stronger antiaggregation is being given, then to change the doses of this medication. But still, we don't have today the good thresholds in the tests for over-response. So this is work in progress, and this needs to be assessed. What about coated flow diverters? Coated flow diverters are just appearing. This is quite old, but the coating is very questionable. Those just came out. Fred X, HPC, P64 from Phenox and Henkes, both seem to have obviously advantage, but it's still work in progress. We need to know when this can, which medication you can reduce, and from the ethical point of view, it's not so easy to determine whether you start a study claiming that you will have less complications if you're not sure. Duration is also an issue. How long to give antiaggregation? And this has been changing with time. Here is a mistake made where dual antiaggregation was given only for 3 months. You see here this extension of the aneurysm that shrunk down. Patient was doing better after 3 months, but at 3 months, clopidogrel was stopped and the artery occluded and she died. Last point, flow diverters and hemorrhage. Is this to be considered? The usual answer is no, but look at this aneurysm here. Is it so good? Everything cannot be done by endovascular, but this is not an easy aneurysm. It just bled. The whole thing is fusiform. To open this has some risk of rupture. You can certainly appreciate it too. And there is an increasing use of flow diverters in such indications where we did it, in fact, and you see here flow diverters were placed, coils were added, and that's to follow up 1.5 years later that we did yesterday. I just added it this morning, and I think that the patient is good. So potentially this is something interesting to consider. So how to interpret the results? You will find believers and the non-believers, but registries usually show excellent results. But there are some potential bias, section of cases, of centers, or positive interpretation of results. And one reason for this can be that there is a positive interpretation of the what is happening. Look at this patient, the basilar dissection. I had to occlude this basilar artery. And then 1 year later, he developed fusiform aneurysms on the P cones. So whatever the technique, they are challenging to treat. I treated flow diverter, new aneurysms developed. I continued to treat, and then we had a fair good result that remained stable. And when we controlled him 2 years later, you see that the artery is gone. So is the result poor or is it bad? It's not good. We lost the artery. But if you consider the other aspect, the patient is good. He's clinically asymptomatic and MR is normal. So as a conclusion, definitely flow diverters have a high efficiency. The thrombogenicity is a problem which is adapting, getting better with time, but the neutral solutions also are carry some issues, and a lifelong interrogation is not ideal. We still have missing data on the duration of antiplatelets, and now it's going to be even also difficult with the new coated flow diverters that are to be used. So in my opinion, definitely very good devices, but not only advantage and to be handled with care. And I think that should be done and on time. Thank you.
Thank you very much, Chapeau. The next speaker will be Peter Baskowski. Peter Baskowski is the chief of La Charité, Berlin, and she is also a very, very well-renowned neurosurgeon. I think it's one of the most representative of the neurovascular surgery nowadays in Europe. And he will talk about the past, present, and future of bypass surgery. That he is a very expert in this topic. So you can go, Peter.
So, dear moderators, dear members of the SENEC, first of all, thank you very much for your kind invitation, for having me with you at your annual meeting, and especially thanks that you asked me to also refer to my former mentor, Professor Peter Schmiedek, who unfortunately passed away in the first half of this year. So I will be happy to give you an update about the bypass surgery for ischemia, the past, present, and the future, with a special, especially referring to Professor Schmiedek. So this is briefly the historical background of EC-IC bypass surgery in the early past. So it started all with the theoretical bypass and then with the development of the microsurgical techniques. Yajagil, of course, was the first to apply bypass surgery to animals and then to patients. And then we had the international cooperative study that was initiated and failed in '85. And since then, and this was really the early time when Peter Schmiedek was a PhD student and then a young resident, he witnessed how this bypass study failed. And he always asked the question, why did it fail? And he came to the conclusion that the most likely reason for this was the insufficient understanding of the pathophysiology of cerebral ischemia. And Peter Schmiedek was really one of the first who introduced CBF measurements in order to triage or to assess patients undergoing bypass surgery. And he understood that there might be a difference between patients suffering from thromboembolus versus those that were suffering from hemodynamic compromise. He defined hemodynamic cerebral ischemia in two ways. Number one, anatomic, which meant an insufficient collateral supply as evidenced by the angiographic study, and on the functional level, by using quantitative CBF measurements as shown on the right side. This could be either a SPECT with a asymmetry index, a xenon CT, or today we like to use waterpet. And he defined the functional, the reserve capacity, the cerebrovascular reserve capacity, as the most important surrogate marker. And if this was impaired, patients were at higher risk for having stroke. This was the concept of Peter Schmiedek when he was a young resident and a postdoc. And in 1994, just before he became chairman in Mannheim, he published this paper really proving that patients that were treated with an impaired cerebrovascular reserve capacity, that were treated with a bypass, would normalize rapidly within 1 week, and this was a durable result up to 3 years. So he was one of the first that had shown that the impaired reserve capacity could be normalized by a extracranial to intracranial bypass surgery, and this was published in the Journal of Neurosurgery in '94. And this was the basis of his understanding that only patients with a hemodynamic compromise, and this is a minority of patients among the large population of patients with steno-occlusive disease, that would qualify for bypass surgery. The larger majority had their ischemic attacks by thromboembolic events or by small vessel disease. So only 10%, either patients with stenosis or with occlusions, would be candidates for bypass surgery. And this was then confirmed by the St. Louis group in their paper in '98, where they have used a PET in order to measure oxygen saturation or extraction. And they could show that patients with a reduced reserve capacity, or as they said, with a misery perfusion, as shown in red, had an increased risk for stroke up to 25% in 2 years. And together with Peter Schmiedek's data that bypass would reverse this reserve capacity impairment, this was the basis for starting new trials and for suggesting that bypass surgery, in fact, has its place in treating patients with ischemia. The working horse for revascularization is the SDMCA bypass, where we use either the frontal or the parietal branch, and initially a big craniotomy was performed in order to identify the recipient vessel and to perform the anastomosis. Today, SDMCA bypass has matured to a minimally invasive procedure with a thick craniotomy, which allows to perform this anastomosis and improve the hemodynamic situation for this patient. Another big success of Peter Schmiedek's work was the standardization of SDMCA bypass. Performing anatomic studies, he identified the end of the Sylvian fissure, the angular region, as the region where the highest number of recipient vessels could be identified. And the quantitative analysis on the right shows that you can find 1 to 3 vessels as a general rule in this area, sometimes even 4. And these vessels are usually of a good caliber in order to allow an anastomosis. And he also developed this easy tool, which allowed to identify the target point, the end of the Sylvian fissure, by minimally invasive means without navigation. This was Pullman's navigation. And this was very precise in order to identify the region where the craniotomy should be performed for the bypass. And this is how it looks like in patients. If we have the frontal branch and the parietal branch, and we would like to use the parietal branch of the STA for the anastomosis, then this craniotomy site will be 6 centimeters above the external auditory external meatus. And therefore, we would perform an incision along the parietal branch and then pull the vessel and the incision over in order to perform the craniotomy here. If we are going for the frontal branch as the donor, we would perform 2 incisions, one along the donor and then a second incision above the craniotomy site, and the vessel will be then transposed, shortened, and the anastomosis can be performed through this small craniotomy at the end of the Sylvian fissure. So Peter Schmiedek was really one of the first that was thinking about a standardized way to perform an STA-MCA procedure in a very quick and minimally and very clean way. So this was another important contribution. With this technique, the surgical results were excellent. The bypass study had already shown a very low morbidity, mortality, and high patency rate, and we were able to keep on that morbidity rate to 6% and to have a patency rate that was 99%. And of course, ICG angiography really helped in order to push the patency rate. Our bypass activities have increased since then significantly. When I started in Berlin, this was the number of bypasses that we had performed, and we were performing bypasses either for aneurysms, Moya disease, or for arteriosclerosis. And we worked quite well with arteriosclerosis, but then the COST trial had suggested that bypass surgery is not efficient in preventing stroke. This had reduced our numbers, and then they had recovered. And today we are performing approximately 20 to 30 anastomosis for atherosclerosis, and the same amount or even a little bit more for Moya disease. We have also introduced new techniques in order to identify our patients. Today we are using water PET, which is superior to the SPECT technique, and we could show that water PET allows to identify 25% that were negative on SPECT that would qualify for a bypass surgery. The question, however, is why can we perform a bypass, or why are we still performing bypasses in the light of, again, negative trials? So we had two trials. Number one was the Japanese trial, and the other one is the COST trial, the American trial. The Japanese trial was positive, but was never published. But it had shown that a good bypass can prevent stroke. However, the COST study was negative, and it was prematurely terminated after 140 patients, 2 years follow-up. And it had shown that the bypass is inferior, or is not superior to the conservative treatment, and the Sampras protocol was used for conservative treatment. And in fact, the conservative arm, surprisingly, was doing very well with a stroke rate that was lower than with the St. Louis trial. However, the bypass arm was doing not so well, and this was mainly due to a high perioperative stroke risk. And don't forget, our stroke rates perioperatively are somewhere between 5 to 7%, and this might be attributed to a reduced experience maybe in centers that had participated in the COST trial. This is the summary of the two studies. JET trial was positive. The COST trial, which is the most important trial since it had been published, was negative, and this was mainly attributable to a high perioperative stroke risk. And now coming back to Peter Schmidek's study or registry or his series, which had shown a 6% perioperative stroke rate, even if you look very closely by MR and not only by clinical signs. So this was a little bit contradictory, and this is why why Peter Schmidek and why we continue to perform bypasses for arteriosclerosis. And we have pushed the envelope. There are new technologies for common occlusion of the common carotid artery, different techniques how to revascularize these difficult situations. For example, using a vertebral artery to M2 bypass using a radial artery graft, which is a complex technique, but which is a very good technique in order to treat patients which are not suffering from internal carotid artery occlusion, but from common carotid artery occlusion. We came up with an algorithm which step-by-step analyzes the vascular anatomy and comes up for a solution for these patients, even with the graph that I've shown you, or with a long graft from the subclavian artery to M2. And we have also came up with algorithms for bypasses for posterior circulation problems. And these are the patients that we are treating today. These are patients with alternative indications, and especially patients with multi-vessel steno-occlusive disease. We have recently published a paper where we have analyzed our series, and we came to the conclusion that the patients that we are treating today are more severely affected than the patients that were treated in COST. 52% had multiple vessel occlusions. Many of them had recurrent TIAs with many comorbidities and with bilateral impairment. really suggesting that patients that undergo surgery today are more affected or more severely affected than the cost population. And this is shown here, 50% with bilateral disease, either also in the hemodynamic impairment. And these patients were also from a neurological perspective more severely affected. In this patient population, we had the same success with our bypasses, and the perioperative stroke rate is now between 3 and 5%, suggesting that it's time for a new bypass, and this is already the future for arteriosclerosis, a new bypass trial which we call the CRAP. These times we will perform a single center RCT. It's already undergoing ethic evaluation. We are planning to include 77 patients, which will be randomized 2-1. And the primary outcome will be the prevention of stroke, and the perioperative stroke risk will go into the primary safety outcome. So we are taking away the perioperative stroke risk from the stroke prevention. Another area of interest of Peter Schmiedek was the Moya-Moya vasculopathy, as shown here, the typical signs with the bilateral occlusions and these typical collateral blood vessel growth. And there are 3 interesting pathophysiological hallmarks: the proximal vessel occlusion, the vessel fragility, which might lead to hemorrhages, and the endothelial cell plasticity explaining the arterial collateralization. Together with Peter Schmiedek, we came up with a grading for Moya-Moya vasculopathy in mild affection, moderate affection, and severe affection, which is mainly relying on readouts of hemodynamic parameters. We could show that similar to the Spetzler-Martin grade, this grading system for Moya-Moya disease, and we are grateful that today this is referred to the Berlin grading system, is able to predict the risk of the surgery. Mild patients have almost 0% of risk, moderate 9%, and severely affected have a risk of 16%. And this has been meanwhile validated by Japanese and by US groups, and they all were able to confirm that this Berlin grading system for Moya-Moya vasculopathy is an excellent way in order to predict the risk of the surgery, and in order to and it very well correlates also with the neurological impairment of these patients. We were also always thinking about the best ways of revascularization, and early on the idea came up that we should come up with a book, a cooking recipe book, which would detail all the surgical techniques for Moya-Moya vasculopathy. And we came to the conclusion that multiple variations exist, and they are all summarized in this book that had been published just before the pandemic. But the concept is that there are indirect techniques and there are direct techniques. With the direct techniques, we are performing a direct anastomosis, and with the indirect techniques, we are putting something onto the brain surface because the angiogenic activity of the Moya-Moya brain will induce revascularization by pulling in new blood vessels. However, this takes some time, while the direct revascularization is successful immediately. Together with Peter Schmiedek, we could show in the adult and in the pediatric population that both techniques work very well, but the indirect techniques like the encephalomyosynangiosis take some time until they take 3 to 6 months, and they only work very well in pediatric patients. In adult patients, even in Moya-Moya, only indirect techniques are unreliable. However, with the direct anastomosis, they work well both in adults and in pediatric patients. In addition, Peter Schmiedek was able to show in a study where he compared the indirect technique alone versus the combined technique, that only the combined technique, due to adding the direct anastomosis, are able to normalize the hemodynamic impairment. And this is why we today advocate strongly that only direct or combined revascularization techniques should be performed, both in pediatric and in adult patients. And this has been recently confirmed by a large number of meta-analyses showing that combined and direct is superior to indirect, and the complications are the same. Today, we have advanced the field. We have created novel strategies for failed bypasses. We came up with an algorithm that would allow to allow the surgeon to use different strategies to revascularize patients that had initially an STA-MCA but then failed. We have used different techniques, classical techniques, and some classical techniques, and that might have resulted in failure. And sometimes the failure was an anytime event, somewhere years after, because of new steno occlusions. For example, we are using today the radial artery graft, which we use from the external carotid artery to the M2 branches, which is a very good technique to treat patients that have failed standard STA-MCA bypasses, giving very good hemodynamic and angiographic results as shown here. And this is the algorithm. Insufficient graft. If the graft has failed, then we came up with different techniques how we can replace and perform new grafts. If the reason is another one, like a new stenosis on the PCA, then we have to go for alternative techniques, revascularize the posterior circulation using an occipital artery graft, for example. So this is what we have done in present. The future for Moya Moya looks a little bit different. It looks less surgically. We have to understand the unique biology underlying Moya Moya disease. The big difference between arteriosclerosis and Moya Moya is that this is a quiescent cerebrovasculature and this is a very plastic vasculature. And although Moya Moya is a very rare disease, only affecting a few patients per year, if we understand the mechanisms underlying the collateralization in Moya Moya, we might have a new treatment for the endemic arteriosclerosis. And this is why we have to learn from Moya Moya in order to treat arteriosclerosis patients in the future. While the concept of vessel occlusion for arteriosclerosis is well understood, we have to better understand why these patients develop steno occlusions and why these patients are able to induce angiogenesis. And if we understand these mechanisms in the future, we might be able to develop novel strategies in order to improve the collateralization for arteriosclerosis. And this is the future for Moya Moya vasculopathy. And I would like to conclude with an early slide of Peter Schmiedek, which he had shown approximately 2005 or 2003, where he was already predicting that the number of aneurysms is going down, the number of surgically treated AV malformations is going down. However, bypass surgery will help the bypass and the vascular surgeons to keep up their activities. And we are now working both in the field of arteriosclerosis and in the field of Moya Moya to develop new areas of revascularization or to maintain the indications in order to increase the number of patients treated and in order to keep up the number of patients treated for vascular surgeons. With this, I would like to conclude and thank you once again for having me and inviting me. Thank you very much for your attention. And goodbye from Berlin.
Thank you very much, Professor Baikosi, for your excellent presentation. It was very, very interesting. Thank you for this the reference to Professor Schmiedek, who passed away this year. And I hope you can stay with us till the end of the table to answer some questions that probably will appear. Thank you again. Bien, ahora tendremos, me parece, unos segundos de publicidad y posteriormente el doctor Ramón Torné iniciará de nuevo la serie para que yo presente de nuevo al profesor González Llanos, al que esperamos tener por aquí pronto. Nos vemos en un instante. Bueno, ya estamos aquí de nuevo. Creo que tenemos ya al doctor Llanos conectado, espero que sí. Y sí, ya lo tenemos. y nos va a hablar de su experiencia. Creo que no hace falta presentarlo, que todo el mundo le conoce, y sin más, pues por favor, proceda.
Buenos días, muchas gracias Luis por la invitación. Mi título es un poco concreto, digamos, aneurismas complejos. Entonces, la primera pregunta es: ¿qué es un aneurisma complejo? ¿Qué es? Luego, ¿para quién es complejo? ¿Es igual para todos los cirujanos o para un mismo cirujano en las diferentes fases de su vida, o para la endovascular o para la microcirugía? Y la tercera pregunta sería: ¿cómo cómo armarnos de herramientas para tratar los aneurismas complejos? Los aneurismas se empezaron a entender, si le preguntamos a estos gigantes de la neurocirugía que empezaron con la neurocirugía, si eran complejos o no eran complejos lo que trataban, vamos a ver un poco de historia. Los aneurismas se empiezan a entender a lo largo del siglo XIX en estudios de autopsia, en Inglaterra, en Francia y también algo en Estados Unidos y en Noruega. En 1885, Victor Hosley trató a un paciente que tenía un aneurisma de la región del quiasma óptico con ligadura de carótida cervical y le llamó gran quiste de sangre. Harvey Cushing en 1920 tuvo una hemorragia masiva, el paciente que estaba operando, de una hipófisis, probablemente el primer paraclinoideo operado que acabó en desastre. En 1924, bastante desconocido, pero una figura de la neurocirugía, que es Wilhelm Magnus, el pionero de la neurocirugía noruega, tuvo, operando una neuralgia del trigémino por vía media, por fosa media, tuvo también un paciente con una hemorragia masiva por un sangrado de un aneurisma cavernoso. Lo trató con ligadura cervical y aparentemente, porque no podía controlarlo, entonces se taponaba con músculo, mirarlo ahí, y con algodón el agujero espinoso, pues tuvo que ligar la carótida cervical. Aparentemente el paciente recuperó lentamente. No sé. Dandy en 1928 trató su primer aneurisma con ligadura cervical, y este es el momento más importante. El abril de 1931, el primer abordaje directo a un aneurisma. Norman Dodd, a un paciente que tenía una punción lumbar positiva y había tenido varios ictus de cerebral media, hace un abordaje frontal con exposición de la bifurcación carotidia y experimenta un sangrado masivo viniendo de la cerebral media. Ni corto ni perezoso, tapó con músculo el aneurisma y comprimió 12 minutos. El paciente fue bien y a los 2 años, a pesar de que no podemos, me gustaría ver esta arteriografía, aparentemente estaba haciendo deporte. Después vinieron los demás: Olive Crona, Drake, Jassar Gil Shunt y los gigantes de nuestros tiempos, ¿no? Spetzler y esta pareja que tenemos aquí abajo. Entonces, ¿qué es un aneurisma complejo? Bueno, pues dependerá de cada uno, ¿no? Lo que es un aneurisma complejo. A cada uno de estos cirujanos en cada momento cambiarían de opinión pensando. Yo creo que una definición objetiva de aneurisma complejo es un aneurisma que es difícil de tratar sin riesgo para el paciente. Y es un concepto dinámico, incluso en la experiencia de cada cirujano. Por eso yo he traído algunos casos para enseñaros recientes de lo que yo ahora mismo entiendo como un aneurisma complejo. Volviendo a los principios de la microcirugía vascular, lo primero que tenemos que aprender en nuestro trabajo es una disección limpia y traumática, navegar por las cisternas, que nos proporcione un control vascular proximal y un manejo de las perforantes. Esto es un ejemplo de navegación cisternal. Esto es lo primero que tiene que aprender un neurocirujano que quiera ser neurocirujano vascular. Navegar tranquilamente por las cisternas, sin romper nada, y luego ya viene el clipaje. El problema es que, ¿qué diferencia a los neurocirujanos cerebrovasculares? Es decir, ¿cuáles pueden hacer aneurismas complejos? Nos diferencia el conocimiento anatómico, las habilidades microquirúrgicas y la experiencia también. ¿Por qué un aneurisma es complejo? La pregunta fundamental. Por su tamaño, por la calidad de la pared y por la localización. Son los 3 factores más importantes. El factor individual más importante es el tamaño. En los aneurismas complejos, ¿qué necesitamos? Necesitamos dominio de la microcirugía vascular, pero para tener acceso a esas localizaciones y control proximal, un dominio de la base de cráneo. Y luego un compromiso de trabajo físico y mental. ¿Por qué? Porque aquí tenemos el primer mito. ¿Son más complejos los aneurismas rotos? Yo voy a resumir mucho sin discutir, no. Nosotros operamos los aneurismas en día 0, me voy a ir de este vídeo al final y lo veréis. El final es lo más importante. Abrimos la lámina terminalis y el cerebro lo dejamos más relajado que nos lo encontramos la gran mayoría de las veces. Dominando, los aneurismas en agudo no son complejos. Ya primera respuesta a las preguntas que teníamos. Y luego, en cuanto a las técnicas, tenemos algunas técnicas específicas para aneurismos complejos. Reconstrucción con clips. Estos aneurismas no se pueden clipar directamente muchas veces. manejo cuidadoso del clipaje temporal, porque necesitan clipajes largos, temporales, y luego tenemos estrategias de clipaje y finalmente el bypass, del que he hablado muchas veces. Abordajes de la base de cráneo, tenemos que dominar el FAR lateral para los de PICA, para los de AICA el CPA. Tenemos que tener un dominio de lo que es el seno cavernoso con estos triángulos, sobre todo para los paracrinoideos, que es de lo que más voy a hablar hoy. Estos, los triángulos anteromedial, el medial y el triángulo superior, el 1, el 2 y el 3. Por ese triángulo 3, por ese triángulo superior, entre el tercero y el cuarto, que no hay nada, hacemos en la técnica de mi plata de Mura con un abordaje para los basilares extraordinaria. También tenemos que manejar los subtemporales. Y entonces nos vamos a los aneurismas paraclinoideos, que son también, hay mucha controversia. En muchos sitios dicen que son todos endovasculares. Yo no pienso lo mismo. Yo creo que los podemos reducir a 3 grupos de aneurismas, ahora veremos. Existe, por supuesto, la opción endovascular. Lo más importante es preservar la visión y la función hipofisaria. Y en función de eso, tenemos que elegir entre endovascular y quirúrgico. Recordar que los segmentos de carótida, cuando hablamos de paraclinoideos, son el C2 y el C3, y en el C2, que desde la oftálmica hasta la comunicante posterior, las únicas perforantes que tenemos son la hipofisaria superior, tanto las perforantes que van a la hipófisis como las que van al quiasma, es muy importante, y a los nervios ópticos. Y el segmento C3, que es el que no tiene perforantes, que es el segmento que está debajo de la clinoides. Este es un trabajo magistral del doctor Mura, que es la persona que más me ha influenciado a mí en el tratamiento de los paraclinoideos. Y vemos que tenemos el segmento C3, bordeado por el anillo proximal y el distal, y tenemos una serie de configuraciones de aneurismas. Tenemos el oftálmico típico, que tiene una proyección superior, distal a la arteria oftálmica. Tenemos el de hipofisaria superior, más distal, y el del cabum o del carotid cave, más proximal en la parte medial. Y luego tenemos estos laterales, que son complejos de pared lateral. ¿Por qué? Porque están justo debajo de la clinoides y suelen ser transicionales, se meten a veces en el segmento propiamente C3. Es decir, vamos a trabajar en los segmentos C3 y C2 de la carótida. Vamos a enseñar 3 tipos de aneurismas recientes. Este es un aneurisma nuestro de este año del carotid cave, típico carotid cave. Vamos a ver la técnica. Lo primero que hacemos es la clinoidectomía. Veis que es un caso izquierdo. Hacemos la clinoidectomía, vamos a ir pasando para que no tenemos mucho tiempo. Quitamos la clinoides, tenemos el segmento C3 expuesto. Hacemos una exposición dural muy limitada. Repito que en todos estos casos, en el 100%, hacemos una craniodectomía miniterional con abordaje extradural inicial. Aquí es muy importante en los CAPE, acordaros que el aneurisma está debajo de nosotros, hacia medial. Tenemos que usar un clip fenestrado. Tenemos que abrir el anillo 360 grados. Hay que liberar la carótida. Y también hay que liberar toda la carótida en el segmento C3. Son demandantes técnicamente. Podemos ser más conservadores en los... Aquí ya exponemos un poquito, también ahí tenemos el aneurisma, lo empezamos a ver, ya tenemos totalmente liberada la arteria en el segmento pues aún tenemos que liberarla más. Entonces, esto ya es segmento C3. Fijaros que hemos tenido que ser súper agresivos con el strat y usamos un clip fenestrado. Un clip fenestrado que, bueno, pues nos permite controlar. El problema de estos es que el espacio es muy limitado, los rectos no siempre valen, a veces usamos curvos, en este caso lo manejamos con un recto de Peter Lasik y controlado el aneurisma de carotid cave. Luego lo revisamos, por supuesto, vemos que no queda nada, nos pasamos al siguiente tipo de aneurisma, que es el aneurisma de segmento oftálmico típico. En estos casos hay que liberar el anillo, por supuesto, pero es un aneurisma realmente de segmento C2 la mayoría de las veces. Son algo más sencillos y muy, muy accesibles por abordaje miniterional. Estamos abriendo la clave, ya veis que es la liberación de la carótida, la liberación del anillo. Tenemos la exposición, lo veis que es un caso derecho. Gran parte del aneurisma está en la cisterna y estamos abriendo el anillo. La clave, como siempre, abrir el anillo. En cuanto lo tenemos abierto suficientemente, un clip recto, el clipaje más fácil que hay, de atrás adelante, con lo cual la craneotomía puede ser muy pequeña. En estos son los que podemos hacer la craneotomía más pequeña. Vamos, con quedarnos en una miniterional, no pasando de la línea temporal superior, es más que suficiente. Y luego el tercer tipo que tenemos son los laterales transicionales. Esto ya, digamos, que es caza mayor. Esto es más complejo por todo, lo veréis. Por la exposición y porque hay parte del aneurisma, gran parte del aneurisma está en el segmento C3 propiamente. Aquí también estamos en un caso derecho, veis el trocito de aneurisma, el poco de aneurisma que vemos cisternal, ese trocito, y el resto está en el segmento C3. Entonces vamos, aquí la exposición también, fijaros que me he saltado una cosa, aquí ya tengo control en el cuello, mirad este punto de aquí. Pongo este clip, ¿por qué? Porque lo tengo controlado en el cuello. Aquí no, ni sueño con tener control proximal en el segmento C3. Entonces pongo un clip distal, lo atrapo ya para quitar el anillo, porque estoy muy encima del clip. Y entonces hacemos una reconstrucción con clips, con 3 clips, en este caso, del aneurisma hasta poder excluirlo. Esto es un aneurisma que aquí estamos ya proximales al anillo en C3. El aneurisma más complejo de los 3, ¿de acuerdo? Cuando hablamos ahora, vamos a hablar de reconstrucción con clips. La reconstrucción con clips la podemos usar en aneurismas pequeños y grandes. Importante entender que en los grandes lo hacemos para minimizar el clipaje temporal, ponemos un clip piloto que nos permita retirar el clipaje temporal y luego seguimos la reconstrucción con otros clips. Pero hay algunos aneurismas pequeños en los que lo tenemos que usar. Un clip, en este caso que tenía 2 aneurismas, uno de cerebral media y uno de comunicante anterior. Fijaros el de media, muy pequeñito, pero esto hay que reconstruirlo. Esto no se puede hacer sin reconstrucción. Es un aneurisma que tiene cierta complejidad. Bueno, este es el otro que tenía. Lo veis, hacemos una reconstrucción. Esto es muy difícil de conseguirlo con el endovascular, ¿de acuerdo? En los aneurismas más grandes colocamos un par de clips pilotos y hacemos la reconstrucción. Objetivo, minimizar el tiempo de oclusión temporal. En cuanto al manejo de las perforantes, que es otra de las características importantes que tiene que tener pues, dominios un cirujano de base de cráneo y de cerebrovascular que haga aneurismas complejos, recordaros el paradigma de los pequeñitos, los de bifurcación carotidia. Nosotros para separar las perforantes usamos mucho el algodón. Vamos corriendo algodones y hacemos el clipaje con el algodón protegiendo las perforantes. Esto es esencial en aneurismas pequeños o en aneurismas más grandes también, en este que tenía también uno contralateral de segmento oftálmico que fue manejado desde una mini terional por contralateral. Lo hicimos los dos. También manejo de las perforantes separándolas. Problema de las perforantes, el vaso más preocupante en este otro carotidio es la coroidea anterior. Os enseño este caso porque es un caso antiguo de hace 3 años, pero tuvimos un vasospasmo posterior sin cambiar los potenciales durante la cirugía de la coroidea anterior, después de la cirugía, por ser muy agresivos. Cuidado con la coroidea anterior, cuidado con ser muy agresivo cerca. Afortunadamente el paciente fue recuperando posteriormente el déficit, pero tuvo una isquemia de coroidea anterior. En los aneurismas de comunicante anterior, las estrategias de clipaje, muy importante. Podemos elegir entre vías terional, ya sabéis, la corriente más anglosajona y europea, y la interhemisférica. Nosotros preferimos la vía terional. ¿Por qué? Porque nos permite tratar aneurismas múltiples, porque solo ponemos en riesgo una pequeña porción de giro recto, no arriesgamos los 2 giros rectos, y porque no olemos el seno frontal, que eso hay que hacerlo en la interhemisférica. Importante, el quitar un poquito de giro recto. Siempre hablamos de que los aneurismas de comunicante anterior, los que van para arriba o para atrás, es más difícil. No, quita un poco de giro recto, que no he tenido en mi experiencia nunca nada de trascendencia y conseguimos campos como este para poder tratar los aneurismas. Fijaros, con una pequeña extirpación de giro recto. En este caso, por ejemplo, importante en los aneurismas de comunicante anterior, el uso de clips fenestrados. Este caso es un caso también con aneurismas múltiples. Ya veis que tenemos muchos con aneurismas múltiples. Tiene una media izquierda y una comunicante anterior que mira hacia el lado derecho. Dices, bueno, no puedo hacerlos queremos hacerlos de una misma tacada, en una misma cirugía. Entonces vamos por el lado izquierdo. Hacemos primero el aneurisma de media izquierdo. El aneurisma de media izquierdo que tenemos ahí tenía sus cosillas, pero damos un clipaje simple. Y nos vamos al de comunicante anterior. ¿Cuál es el problema? Que mira hacia el otro lado. Entonces, en este caso, hacemos un clipaje temporal y tenemos que trabajarlo con clips fenestrados. Podemos venir desde este lado, pero hacemos uso de clips fenestrados. Y con 3 clips fenestrados es perfectamente fácil, respetando las perforantes, tenemos control de perforantes, de todo, hacerlo desde el otro lado. Muy importante los clips fenestrados para simplificar el trabajo en comunicante anterior, ¿de acuerdo? Cuando son gigantes, este es un aneurisma que me mandaron nuestros amigos de Córdoba. Cuando son gigantes tenemos que usar la vía interhemisférica. La mayoría de las veces tenemos que usar bypass lateral, pero en este caso conseguimos una reconstrucción simple, pero por vía interhemisférica. como nota de los clips fenestrados que a mí me gustan mucho, fijaros este de cerebelosa basilar, que teníamos una exposición limitada por un pretemporal. Ahora, este por supuesto, le podemos hacer uniplata, liberando más el tercero, tendría un acceso, pero para no tocar el tercero, con un fenestrado conseguimos un paciente sin déficit, dejando en la fenestración el tercer par. Los aneurismas de M1, esto lo hemos hablado, hemos hecho una presentación al respecto este año, solo tratando de los de M1, con lo cual me lo voy a saltar un poco, solo deciros que el objetivo tiene que ser bypass, reconstrucción y oclusión. ¿Por qué reconstrucción y oclusión? Porque si no lo reconstruimos, existe posibilidad de que tiren émbolos. Y tenemos que ocluirlo proximalmente para salvar ese trozo de arteria enferma, pero tenemos que respetar las perforantes. Si hacemos esta técnica, fijaros en este caso, preservamos todas las perforantes. Este es un caso roto, un aneurisma roto en agudo que se ha podido manejar. O sea, este es el tratamiento ideal en los de M1. Y entonces, en los aneurismas carotídeos, para concluir la sesión, ¿cuándo se pueden reconstruir? Pues va a depender del calcio y de la calidad de la pared. Si no hay calcio, la mayoría de las veces se puede reconstruir. Y entonces os traigo este caso, que es muy curioso porque, bueno, son dos aneurismas paraclinoideos bilaterales. Una mujer que se presenta este verano es referida desde Guadalajara a nuestro hospital por problemas de visión. Veo calcio, pero creo que se puede reconstruir. Entonces, planteamos vemos que tenemos un aneurisma derecho con proyección medial del segmento C2 y un aneurisma oftálmico típico grande, oftálmico clásico del lado izquierdo. Entonces, este verano le hicimos una primera cirugía el 26/7 del 2021 con clipaje del derecho. También tenía proyección medial, por eso, entre otras cosas, y la afectación era más derecha la visual que la izquierda. Pues, y ayer mismo le hicimos el clipaje del izquierdo. ¿De acuerdo? Test de oclusión, para finalizar. El test de oclusión muy importante para marcar lo que hacemos con los aneurismas que no se pueden reconstruir. Aquí tenemos un caso, el último caso que os presento, que tiene un aneurisma gigante del segmento carotidio y uno pequeño del cerebral media izquierda. En este caso, hacemos un planteamiento a mayores. Difícil la reconstrucción, aquí ya siempre bypass previo. Exponemos el cuello en el primer paso, hacemos el bypass, navegación cisternal, exponemos el aneurisma, hacemos primero el abordaje extradural con clinodectomía para el abordaje C3. Una vez tenemos ya la exposición intradural del aneurisma, abrimos el anillo y tratamos de tener el control proximal que conseguimos. Antes ya de ir a la fase final, una vez tenemos ya expuesto el control proximal, vemos que va a ser difícil reconstruir, probamos a poner un clipaje temporal. Acordaros que tenemos en el cuello para hacer aspiración, estos casos lo hacemos con aspiración, nos quitamos del medio del cerebro al media, lo clipamos y ahora ponemos un clip distal proximal a la comunicante posterior y aspiramos el aneurisma. Esto es la técnica de suction de compresión típica. Ya lo estamos haciendo con bypass, nos da igual. Este paciente tenía circulación colateral, pero no toleraba el test de oclusión. Entonces ponemos el clip, pero en este caso, para poder excluirlo, debido al calcio, tenemos que ocluir la carótida. Ocluimos la carótida siempre proximal a la comunicante posterior, teniendo en cuenta de no lesionar la hipofisaria superior. Y esta es la situación final. Tenemos, por un lado, tenemos la circulación colateral y por otro el bypass complementando la situación. Y esto es todo. Muchas gracias.
Muchísimas gracias, Kiko. La verdad es que te agradezco que te hayas mantenido en el tiempo y efectivamente tienes la virtud de parece, como has dicho al principio, todo depende, es difícil o no difícil según el que lo vea y realmente, según te vemos, parece que haces fácil lo difícil y tanto quirúrgicamente como de manera de entenderlo. Muchas gracias. La discusión será al final de la... Dejo a...
Pues pasamos al próximo ponente, el doctor Lawton, Michael Lawton. Michael Lawton currently is head of neurosurgery at the Barrow Neurological Institute. Dr. Lawton has an amazing clinical and research activity. Did some research about that. Now he has done more than 900 ABMs, more than 600 papers. and more than 5,000 aneurysms. So I think that's amazing, no? And he will talk about his presentation will be about his opinion in the treatment of grade 3 AVMs.
Greetings. This is Michael Lawton, and I want to thank you for allowing me to present at your meeting. This talk will be on the microsurgical selection of brain AVMs, grade 3 and beyond. AVMs come in so many different sizes and shapes that it's easy to lose the forest through the trees. This slide is meant to show the incredible variability of AVMs that we find in clinical practice. I developed this AVM taxonomy to try and help see the forest through the trees. And the idea is to have 7 types, which are listed to the left, and subtypes listed in the center. The combination of type and subtype helps to identify an AVM for what it is and to help categorize these mentally so that we can recognize a lesion and not be fooled by its anatomy and surgical strategy. So every AVM begins with a type. The 7 types are listed here and include frontal, deep, parieto-occipital, temporal, periventricular, brainstem, and cerebellar. Each AVM type has multiple subtypes. The AVMs are typically shaped as a cone, and the base of the cone is based on a surface of the lobe. So for the frontal AVMs, as an example, there's a lateral surface, a medial surface, a basal surface, and a sylvian surface. And AVMs that are based on any of these 4 surfaces form a subtype of the frontal AVM. The paramedian is a special inclusion here because so many of these frontal AVMs sit at the intersection of the medial and lateral surfaces. As another example, the cerebellar AVMs have 3 surfaces, a suboccipital surface, a tentorial surface, and a petrosal surface, and these are 3 of the 5 subtypes for cerebellar AVMs. There's also many AVMs seen in the vermis and a rare number seen in the tonsil, completing the 5 different types of cerebellar subtypes. It's important to develop a strategy for the surgical removal of these AVMs, and I refer to these battle plans as little summaries of this resection strategy. This illustration shows a lateral frontal AVM, and you can see that with a cube, you can map out all of the feeding arteries and draining veins anatomically to the different sides of that cube. It helps you to identify where the action will be as you remove the AVM. The illustrations in the bottom show the numbered steps from 1 to 8. As one goes through the resection, you go from subarachnoid exposure to identifying draining veins and feeding arteries, to then moving through the phases of the resection from pia to parenchyma to ependymum, and finally at the end, closing off the draining vein and removing the nidus. These are those AVM resection steps. It's important to follow these in an orderly way and not to engage the AVM too early before you've adequately dissected the subarachnoid margins and identified the draining veins and feeding arteries. Each one of these steps is almost a lecture unto itself, but I'll just talk about feeding arteries. This illustration shows how there are many different types of feeding arteries. There's the terminal feeder that ends in the AVM and can be occluded right at the margin of the nidus. But then there's the transit artery that has a distal portion that feeds normal brain beyond the AVM. This has to be carefully skeletonized from distal to proximal in order to preserve that distal flow. Then there are the deep perforating feeders that go through the white matter. There are the choroidal feeders that come from the ventricle, and these can be challenging to obliterate because the walls are so thin. Lastly, you have bystander vessels that are near the AVM but don't give any supply and need to be carefully protected. The illustrations to the right show an example of the en passage artery that must be skeletonized in order to devascularize the AVM while also preserving distal flow to the brain. The AVM box is another important concept. I alluded to it earlier, but the box allows you to map out the feeding arteries that supply the AVM, the draining veins that drain the AVM, and the areas of eloquence. By mapping out these components, you can really plan for your surgical steps as you move through the resection. You know where to find the arteries and veins, you know where to protect the eloquence, and it helps you organize your strategy. The box is also helpful because it breaks the dissection down into these phases. The first side is the peel side, usually on the cortical surface. The next 4 sides are the parenchymal sides, as one dissects circumferentially around the nidus. And then finally the ependymal side as it deepens to its tip of the cone, normally near the ventricle. Now, a lot of our decision-making is based upon our grading of AVMs. We all know the Spetzler-Martin grading system that categorizes AVMs from 1 to 5. Dr. Spetzler, towards the end of his career, collapsed his grading system into these A, B, and C classes as a way of simplifying the grades. He felt that the class A was really appropriate for the grade 1s and 2s, and resection was advocated for those. The class C AVMs were the high-grade lesions where no treatment was recommended. The class B AVMs were the grade 3s that were in the middle and required a multimodality treatment plan. The illustration to the right shows how this Spetzler-Ponce grading divides the AVMs into 3 equal classes. In my view, AVM grading gets better with more granularity and additional variables. This is a picture of Bill Young, who I worked with for many years in San Francisco, and we came up with a grading system that was analogous to Spetzler-Martin grading in its construct, but looked at 3 additional variables: age, bleeding, and compactness, what we call the ABCs of AVMs. By assigning an additional supplementary grade to every AVM and adding the Spetzler-Martin grade plus the Lawton-Young grade, you can arrive at a supplemented grade that really gives a good handle on the surgical risk. We validated our grading system in this multi-center study with patients from UCSF, Barrow Neurological Institute, Mass General, and Macquarie University. And the data here shows that this supplemented Spetzler-Martin grading nicely predicts AVM outcomes. The graph to the right shows that the accuracy of supplemented Spetzler-Martin grading is higher than what you would get with Spetzler-Martin grading alone. The grading is useful for dealing with high-grade and deep AVMs because it helps to define the upper limits of operability. How is it best to define this? You can use Spetzler-Martin grading alone, you can use the Spetzler-Ponce grading classification, or you could use this supplementary grading system. I have come to prefer this supplemented Spetzler-Martin grading and have arrived at an operability limit of 6. This is data that came from our multi-center validation study, and you can see how the outcomes worsen in the higher supplemented Spetzler-Martin grades, grade 7 and above. This line in the sand was suggested by the data here, but we wanted to validate this with additional study. This is our current algorithm for managing high-grade AVMs. When the supplemented Spetzler-Martin grade is less than or equal to 6, this defines the operable AVM. We evaluate the patient for embolization, and we proceed with microsurgical resection. When the supplemented Spetzler-Martin grade is greater than 6, this is one that probably should not be operated, and we consider them for radiosurgery. If the nidus is small, simple stereotactic radiosurgery with or without embolization is recommended. For larger AVM niduses greater than 3 centimeters in diameter, a volume-staged radiosurgical approach is used. There are some patients who simply are not candidates for radiosurgery, and for those, observation is recommended. Our hard cutoff of supplemented Spetzler-Martin grade 6 was suggested by the multi-center study, but is this limit correct? We used data from the Barrow Registry for Aneurysm and Vascular Outcomes to study intermediate grade AVMs, or AVMs with a supplemented Spetzler-Martin grade of 5, 6, or 7. You can see from my surgical series and Dr. Spetzler's surgical series, we were able to identify 246 intermediate grade patients. Here are the outcomes of those patients stratified by supplemented Spetzler-Martin grade. The Spetzler-Martin grade 7 patients had a worse modified Rankin score at last follow-up, and this was statistically significant. They also had a higher percentage of modified Rankin scores greater than 2 as their final outcome, and this also was significant. There were no statistically significant differences in terms of death, complication rate, or AVM residual. When we looked for predictors of poor outcome, we found that supplemented Spezza-Martin grade of 7 was significant. In addition, advanced age and rupture were also significant. These data help to define or confirm that the Spezza-Martin grade 6 cutoff was the appropriate one. We then asked the question, are there supplemented Spezza-Martin grade 6 AVMs that are still dangerous for surgery? And conversely, are there any supplemented Spezza-Martin grade 7 subtypes that might be safe for surgery? And what we found in the top of the graph was that the patients that had large AVMs and were older tended to do worse than the other grade 6s, and that these might be something to beware of. These are what we call a supplemented Spezza-Martin grade 6 plus. With the grade 7 subtype, we found that those with small AVMs and young in age tended to do better than the rest of the grade 7 patients. You can see that the rate of worsening was significantly different than what we saw in the older and larger AVMs. These are what we now refer to as the supplemented Spezza-Martin grade 7 minus. So what we've established is a cutoff of 6 or less for operability, but these 6 plus subtypes are ones that might be less favorable for surgery than one would expect. The way to remember these various subtypes are that these are the ones that are older in age and larger in size. Conversely, the supplemented Spezza-Martin grade 7 patients that do better with surgery than one would expect are the ones that are smaller in size and younger in age. There are 2 subtypes here shown in this slide. This is a graph that depicts that operability limit. You can see that the grade 6 AVMs in green, where it says operable, are all AVMs that we would recommend surgery for. To the right of the graph, those under the red inoperable bar are ones that we would not recommend surgery for. There is this gray zone in the middle where some of the grade 6s are worrisome and some of the grade 7s are operable, and so it's important to remember these subtypes within the supplemented grading system. One of the things that I hope to show with this study was that with experience, one could push the limit of operability. However, this graph shows that the change in outcomes over time, or years in practice, remained completely flat. My patients are shown in blue, and Dr. Spetzer's patients are shown in red, and you can see that between the 2 of us, we were unable to push the curve upwards over time. Similarly, in this graph, we have only the supplemented Spezza-Martin grade 7 patients, and again, we found that we could not push this curve up either with increasing experience, and came to the conclusion that AVM grade at this level of the grading system means that these AVMs are tough, the anatomy is ferocious, and these are better dealt with conservatively. To summarize, we established an operability limit of supplemented Spezza-Martin grade 6. Patients with a supplemented grade between 2 and 6 are recommended for microsurgery. Patients with a supplemented grade greater than 7 are recommended for observation or volume-staged radiosurgery. There are those that we call subtypes. The 6 plus is the large and old AVM, and we recommend observation or volume-staged radiosurgery. Then there is the supplemented grade 7 minus, which are small AVMs in young patients, and these we still consider for microsurgery. This is a summary of my AVM experience over 24 years. You can see I'm approaching 1,000 AVMs. You can also see how my numbers relate to Dr. Spetzer's career numbers. What's interesting to me is how my personal surgical volume, which represents that of one surgeon, was greater than 50 times the number of operative cases in the Aruba trial. So here is a case example. This is an AVM that is located in the midbrain on the posterior aspect. The patient presented with an interparenchymal hemorrhage, which is seen on the CT scan to the left. Her initial angiogram did not show any AVM. She returned for a follow-up angiogram 2 months later, and you can see on this study that the AVM has now come into view. You can see it best on the lateral within that blue circle where there's a small tuft of abnormal arteries and an early precentral cerebellar vein going up to the vein of Galen. This is an example of a posterior midbrain AVM, which is depicted here in these illustrations. It's on the back of the brainstem near the quadrigeminal or tectal plate, and it's approached through a supracerebellar infratentorial approach. Here is our AVM box, which summarizes the anatomy and strategy. The inset to the left shows the torcular craniotomy and the midline skin incision through which this is made. The cube to the right shows the mapping of the feeding arteries shown in red. These are long circumflex perforators and branches off of the superior cerebellar artery, the S3 segment. The draining veins are either these tectal or mesencephalic veins. In this particular case, it was the precentral cerebellar vein. Here's an overview of the surgical exposure. The patient is in the sitting position, and gravity is retracting the cerebellum to open that supracerebellar plane. The initial approach is over the cerebellum. We've drained CSF so that the cerebellum sags, and this gives us this beautiful exposure and entry into the quadrigeminal cistern. I'm working to either side of the vermis, and you can see this arterialized vein that comes into view. You can see that arterialized blood mixing with the venous blood within the vein. The dissection deepens into the quadrigeminal cistern. The occipital lobe pooches over the edges of the tentorium. The collicular plate here is coming into view. There's some small veins that join the precentral cerebellar vein. More importantly, you begin to see here these feeding arteries as they wrap around the tectum. This is just a superior vermian vein which is divided. It gives us a little bit more freedom and access to the collicular plate. Our IC green video angiogram validates that this is the draining vein from the nidus, and now we can begin our dissection of the AVM itself. I'm looking for feeding arteries as they come around and enter the nidus, and here is one. I'm cauterizing and dividing this as it enters into the pial surface of the tectum. Feeding arteries are cauterized and divided, and with each one of these divisions, we help to further define the border of the AVM. And now we begin to define this margin of the nidus here. The AVM is being lifted up, and as that AVM elevates, we can see these feeders that are coming in from below. Here's a little piece of the AVM coming out here. Here's a nice overview shot showing the superior colliculus, that precentral cerebellar vein, which by now is darkened. There is no flow into that vein. This tells us that we've dearterialized the nidus. So we can cauterize and divide the vein, which is being done here. We can now sweep the nidus up and out of its resection cavity. You can see it elevating here. And as we do, this very small nidus is circumscribed and removed. This gives you a very nice view into the aqueduct of Sylvius. You can see the view upwards into the third ventricle from below. Here's our stump of the precentral cerebellar vein. Here's our final overview. The postoperative angiogram showed no evidence of any residual AVM, and the patient did well. For AVMs in the medial hemisphere, it's intuitive to want to put the AVM nearest to the surgeon, in this case on the downside, and come at it from above. You can see, though, that this surgeon's point of view makes it very difficult to get around the lateral margin of the AVM. What's counterintuitive is to go contralateral. By going contralateral, the AVM is further away from the surgeon, but paradoxically, the view around the harder side of the AVM is actually easier to see. And the surgeon's point of view is across the nidus and into that more difficult plane of dissection. So you get gravity to open up the interhemispheric fissure, you get gravity to pull the AVM into the surgical corridor, and it makes things easier. These illustrations show the two different approaches side by side. On the left is the intuitive approach with the lesion down and having to kind of work your way under the AVM and elevate it into the surgical corridor. Whereas on the right, you see that with a window cut through the falx, you have access to the nidus. You can dissect that lateral plane more easily, and as you do so, the AVM falls into the surgical corridor and gives you a nice view over the top. Here's an example of that concept. It's a small AVM, but it demonstrates the idea. The AVM is in the corpus callosum and in the lateral ventricle on the patient's left side, but we're going to go from the right and use that contralateral trajectory to facilitate the resection. Here is our AVM box. You can see with the patient's head turned so that the midline is horizontal, we allow gravity to retract the right hemisphere. The left hemisphere is on the upside. The feeders come from the pericallosal vessels on both sides. They dive into the corpus callosum and feed the AVM. And you can see in the bottom panel the dissection steps that we've been talking about. Here is the dissection down the interhemispheric fissure and into the callosal cistern. This is the pericallosal artery, giving off these small branches that feed the AVM. They are skeletonized or cut one by one, and now we can work our way into the corpus callosum and around the margin of the nidus. These are beautiful AVMs because they abut the CSF of the lateral ventricle. Here is a view of a draining vein, which I'm going to preserve for drainage until later. So we work around the vein, we get on that posterior margin of the nidus, and we continue our dissection into the corpus callosum. This is a septal vein. You can see it draining medially and down onto the surface of the septum. This is what we'll base our resection on. Here now is where that contralateral trajectory comes into view. I'm working away from myself. The AVM is falling into my field of view, and it makes it much easier to get around this thing as the AVM and gravity help pull this thing into a better place. Here I'm getting through the ependymma of the roof of the lateral ventricle, and you can see the AVM descending into view. There's a nice view there of the draining vein on the undersurface, and here the AVM has been circumscribed. As I lift the AVM, I can see that the septal vein draining the nidus into the ventricle has turned blue. Therefore, I can divide the draining vein. This completes the resection, and I can remove it en bloc. It's a very simple AVM, but it's mainly to demonstrate the concept. His postoperative angiogram showed complete resection of the AVM, and he had an excellent outcome. In conclusion, microsurgical resection remains the first line or gold standard therapy for brain AVMs, in my view. Judicious patient selection requires knowing our operability limits. Precision in patient selection comes from the supplemented AVM grading system, which is the combination of Spetzler-Martin and Lawton-Young or supplementary grading. My operability limit is a supplemented Spetzler-Martin grade 6 AVM. I think it's important to push the boundaries with the 7- subtype or the small and young patients, but we must be aware of the grade 6+ subtype, which are the large and older AVMs. Making good decisions and pushing the boundary is the key to getting good outcomes. I want to thank you for allowing me to join your conference, and I hope you enjoyed my talk. Thank you.
Thank you very much, Dr. Lawton.
Bueno, creemos que tenemos algún problema con la conexión con el doctor Lawton, que no se va a poder conectar en directo. Y vamos a dar paso ahora a la presentación del profesor Pablo Rubino, quien es un claro ejemplo de que un gran anatomista, un gran cirujano, suele ser y es un gran anatomista. Él es un excelente anatomista y un extraordinario cirujano. Por favor, pasemos a su presentación.
Muy buenas tardes a todos. En primer lugar, quiero agradecer a las autoridades de la Sociedad Española de Neurocirugía por la invitación a esta importante reunión. Es realmente un privilegio y un honor para mí formar parte de la misma. Voy a hablar sobre anatomía aplicada a lesiones vasculares. Como es un tema muy extenso, he decidido limitarme solo a una región, la región paraquinoidea, para el tratamiento de los aneurismas en esta región, dado que es todo muy extenso para resumirlo en 20 minutos, y creo que esta es una parte anatómica, tal vez para mí, más interesante de circulación anterior. Por otro lado, esta sección está formando parte junto con varios invitados internacionales, por lo tanto, Voy a continuar mi disertación en inglés. So my topic will be microsurgical anatomy applied to the paraclinoid aneurysm. As I usually do, I like to start with the surgical case. This is, at least for me, a challenging case. This is a giant ophthalmic aneurysm. So in this case, to treat this aneurysm, I think that we need to know very well the microsurgical anatomy. Not only the approach we need to do to expose this aneurysm, we also need to complete a wide opening of the sylvian fissure. And finally, we need to know how to remove the anterior clinoid of the process in order to have proximal control of the clinoid segment of the carotid artery. And then we need to open the distal dural ring. Finally, we can expose the neck of the aneurysm, and then not only clip the aneurysm, but also we need to remove, because the mass effect is damaging the visual field of the patient. So all of these steps we can complete because we know the microsurgical anatomy, in this case of the paraclinoid area. Okay, this is the post-op control. When we are talking about the paraclinoid aneurysm, we need to know very well the anatomical aspect, not only in the clinoidal region, but also in the cervical portion of the carotid artery. We have to master some technical aspect. We need to know clinical aspect, and of course, we need the expertise of the surgical team. Regarding the anatomical aspect, as we know, the clinoidal process is the posterior and medial projection of the lesser sphenoidal wing. This clinoidal segment or clinoidal process has three attachments to the skull base. One is lateral, which is the lesser sphenoidal wing. Then we can find an anterior medial, which continues with the roof of the optic canal. And finally, we have a posterior and medial one, which is the optic strut. As you can see here, the optic strut is the floor and or the inferior and lateral limit of the optic canal. So just above, we can find the optic nerve, but also is the superior and medial aspect of the superorbital fissure. So just below the optic strut, we can find the oculomotor nerve. And behind of the optic strut, we can find the carotid artery. So we need to remove all of these three attachments in order to take the clinoid process out. So when we are drilling this area, we have to know and take in account the neural and vascular structure that are very close to the clinoid process. Okay. On the other hand, sometimes in a paraclinoid aneurysm, we need to know the anatomy of the cervical portion of internal carotid artery. And remember that the internal carotid artery starts at the level of the fourth cervical vertebra, when the carotid divides into two branches, the external carotid artery and the internal carotid artery. This is the first segment that we call cervical portion of internal carotid artery. And as you can see here in this dissection, just lateral to the cervical carotid artery, we can find the internal jugular vein, and posteriorly the vagus nerve. So we need to know this anatomy because sometimes we need to expose the cervical carotid artery to have a proximal control in case we need to deal with a giant aneurysm or rupture aneurysm. In case we need to do some maneuvers like a suction decompression, and of course, in case we need to do a high flow bypass, we need to expose and we need to know very well the anatomy in the neck, okay? Then we need to move to the cavernous portion of internal carotid artery in order to remove the anterior clinoid process, as you can see here. So after removing the anterior clinoid process, we can expose the clinoid portion of internal carotid artery. I'd like to describe, or I'd like to say something regarding the cavernous portion of internal carotid artery, because it is the portion which is in contact or in relation with the anterior clinoid process. Remember that in the cavernous sinus, we can identify 5 portions of internal carotid artery. The first one is the posterior ascending segment after passing the petrolingual ligament. Then we can find the posterior vein. Most of the time here we will find the meningohypophyseal trunk. Then we have the inferior lateral or horizontal portion of internal carotid artery. And then the carotid main an anterior vein, which is here. And finally, the most controversial area of internal carotid artery that we call anterior in the cavernous sinus, that we call anterior ascending segment, but we can also say the clinoidal segment of internal carotid artery. And here there is some controversial point, and I think this is important to know. In this segment, we can identify these 2 dural rings, the lower one, which is the proximal dural ring, and the superior one is the distal dural ring. Okay, and these 2 rings delimit the clinoid segment of internal carotid artery. From an anatomical point of view, this segment, the clinoid segment, is not part of the cavernous portion of internal carotid artery and is not in the intradural aspect of the artery, of course. This is from an anatomical point of view, but as you can see here and many other specimens, we can find here venous channel and venous connection with the cavernous sinus. And when we are removing the clinoid process in the surgery, many times we can observe a vigorous bleeding coming from the cavernous sinus. So, from the surgical point of view, we can consider this area as part of the cavernous sinus. But from an anatomical point of view, it's a different segment by itself that we can call clinoid segment of internal carotid artery, and is in very close relation with the clinoid process. The inferior aspect, we can find the proximal dural ring, and at the superior aspect, we can find the distal dural ring. Another topic that is very important to know, at least for me, is that these 2 rings are different because the proximal dural ring is not so tight to the carotid artery as the distal dural ring, because the distal dural ring is very tight we can consider in 360 degrees. So this is the reason that in the proximal dural ring we can find this venous connection, and the distal dural ring is very tight to the carotid artery, except in some cases, as you can see now, in the posterior and medial aspect, that sometimes we can find like a pouch that we call a cave. And here we can find, in some cases, the carotid cave aneurysm. And this is another controversial point because the carotid cave is not present in many cases, and in some cases it's just a very narrow space. So this is another controversial point, and this is important to know regarding the distal dural ring. After knowing this anatomy, we can consider the aneurysm in this area. Okay, there are many classifications I follow the Vandross one, which is the simplest. He divides into majorly two kind of aneurysm: the superior one that we call the through ophthalmic aneurysm, and the inferior one. But we can also consider the medial one, which is the hypophyseal aneurysm. And when the medial one is at the level of the distal dural ring, this is the variant that we call carotid K aneurysm. There are many classifications. I think that all of them are very well, but the surgeon can take the different ones. I think that the Alucris classification is also another very complete classification, and we can use any classification. I think that the most important thing is to know the anatomy in this area to understand and deal with this kind of aneurysm. Okay. Regarding the technical aspect of paraclinal aneurysm, you know how to expose the carotid artery in the neck. We need to master the terional approach and its variant, I mean a mini terional approach. We have to know how to remove the clinoid process, intra or extradural. We have to be prepared for reconstruct the artery, and of course we need to know cerebral revascularization techniques. But as you can see, the first three elements are very important, and these are pure anatomy. So the anatomy is the key in many surgery, but especially in paraclinal aneurysm. I'd like to share some cases how I treat this kind of aneurysm. I will use example from superior and inferior and medial, and this is the first case I'd like to show. This is a very simple case. The patient came to me for a second opinion because he was offered a Freud averter, and I think that this very simple aneurysm can be resolved with a what can I say, in a 20-minute intradural surgery, just with a very simple maneuver. I just cut the falciform ligament, which is a dural fold. It's not a ligament, but we call falciform ligament. And then we can identify the carotid artery. We have we can expose the neck. We can expose the aneurysm in 360 degrees. Then with the Kerrison and a micro scissor, just remove 1 or 2 millimeters of the roof of the optic canal, and that's all we need to treat this aneurysm. I think that 20-minute surgery, and we can complete a very good clipping, and we resolve this case easily. Okay. And then we can move for a more challenging case. This is a large ophthalmic aneurysm. In this case, the neck is wider than the previous case. We did the terional approach. We start the opening of the sylvian fissure from lateral to medial at the level of the pars triangularis, which is the easiest point to start the opening. After completing the wide opening, I just put the retractor and I can expose the neck. In this case, I realized that we need to complete the anterior clinoidectomy. So I dissect the inferior border of clinoidic process. Then I dissect, I drill just medial to the optic nerve. Then I just complete the removal of the clinoid process in one piece, as you can see now. And then I made a partial opening of the distal dural ring. As you can see, this aneurysm. So I just put a slight curve clip to treat this aneurysm. After clipping, I check, and I could see that some part of the aneurysm was not involved by the clip. So maybe I remove the clip. I knew that maybe I need to complete a better opening of the distal dural ring. So if you know anatomy, you know the structure and the configuration of the ring. So I start a better opening of the ring, as you can see now, because maybe the ring was the problem to get a good clipping in this case. So with the micro scissor, I complete a larger opening. Then I put some more firing glue to control the bleeding. And now I can clip much better than before, as you can see, because of the correct opening of the distal dural ring. It's not only remove the clinoid process, but also remove and opening the distal dural ring, coagulate and puncture the aneurysm, and this is the final result. This just applying the microsurgical anatomy. This is a post-op angio, and the patient did very well. Then we can remove the anterior clinoid process by an extradural road. I think that the anatomy is the same, so there is no difference, but I prefer intradural because in 20% of my cases, I don't need to remove the anterior clinoid process. This is another superior ophthalmic superior variant of the paraclinoid aneurysm. So in this case, I did the pterional approach. Okay, I will fast forward a little. And then after completing the pterional approach, I drill the lateral wall of the orbit in order to expose the periorbital tissue, as you can see here. And this is a very important step. You need to identify here this structure that we call the meningo-orbitary band. Here we find the periorbit, and here the dura covering the temporal lobe. This is the meningo-orbitary band. So we can cut with the micro scissor, and then we start a mini medial fossa peeling. Mini means you need to expose the lateral aspect of the anterior clinoid process. So here I just dissect 1.5, 2 centimeters of the lateral wall of the cavernous sinus. I put some firing glue to control the bleeding. The following step is just similar to the previous one. Maybe the vision and the drilling is more lateral than in the intradural, but just the attachments are the same. So we need to remove the 3 attachments in order to take the clinoid process out. Here I am removing in one piece the anterior clinoid process. Then just put a Doppler to see that I have a proximal control of the clinoid segment of the internal carotid artery. And then just complete an opening of the dura just in the depth of my craniotomy in a T-shaped configuration, one side to the temporal lobe, another to the frontal lobe, This is all that we need because we are just in the depth of our dissection. We can identify here the optic nerve, carotid artery. You can see here the ophthalmic aneurysm. Similar to the previous case, we need to open the distal dural ring in order to put the clip properly. After completing the opening the distal dural ring, we just go with the slide curve clip, and that's all. So this is another way. So we can use intradural, extradural, but the anatomy is the same. So it depends of the surgeon preference. Regarding inferior one, I move once again to the lab and dissect again this area. And in the inferior one, most of the time, we need to remove the anterior clinoidal process. We need to open the distal dural ring. We need to work around the proximal dural ring and expose the clinoidal segment. And most of the time, we can resolve this aneurysm using a fenestrated clip. Here, one more example of an inferior one. This patient has another Picon aneurysm. So we did the pterional approach, as you can see here, and then we start the drilling, as usually. And after completing the removal of the 3 attachment, we complete an opening of the distal dural ring. In this case, is very tight to the carotid artery. After opening the distal dural ring, we can expose the neck in 360 degrees. I just put the dissector in the anterior and lateral part, another now in the anterior and medially. So now we have enough room and very good exposure to put a fenestrate clip to treat this aneurysm. Okay. Of course, before and after clipping, we check the flow. We use it with the use of Doppler. Then a very simple Picon aneurysm was clipped. One of my senior resident, as you can see now, with the lateral curve clip. And the patient did very well. I have one more case, but maybe because of the time I will skip this case just to show some more example. Regarding to the medial one, I only operate the aneurysm which are distal to the distal ring. Most of the time, I prefer to operate with the contralateral aspect. It was aneurysm previously coiled, and you can see that the remnant here was growing, so I decided to use a contralateral approach and clip. And this is the way I like to use. And finally, I like to start with this case, and this is the giant ophthalmic aneurysm. And here, just to conclude with another case, just to conclude and emphasize how you need to know the anatomy. I try to clip, but in this case, I prepare for it. The bypass. I did a pterional approach, and then after start the bypass, I expose the carotid artery at the level of the neck. I did the opening of the Sylvian fissure, and I just exposed the aneurysm. For me was impossible to clip, so I moved to the Sylvian fissure and exposed the M2 segment of the anastomosis in the intracranial aspect first, And then I move to the neck and complete the anastomosis in the neck. So for all of these steps, we need to master the microsurgical anatomy. This is the final result. There is no more aneurysm, and the bypass is working very well. Okay, so we need to master the microsurgical anatomy of this complex area, and we need to master the microsurgical techniques. We have to know how to deal with the cervical carotid artery, how to remove the clinoid process, intra or extradural, and be prepared for clip reconstruction of the artery. And of course, we have to be prepared for revascularization techniques. I want to thank you very much for your attention, and I'd like to finish with this picture of my mentor, maybe one of the best vascular surgeons of the history, the giant, my friend, my mentor, Evandro de Oliveira. Thank you very much for your attention.
Bueno, creo que tenemos algunos problemas para conectar con los profesores Lawton y Hello, Peter. Thank you very much.
Hello.
Nice to see you. I think
Thank you very much for having me.
Okay.
It's an honor for us. We have some problems with Professor Lawton and Professor Rubino.
Yeah.
So if the rest of the panelists want, we are. Is Rene here also? Okay, perfect.
Hello.
I think we are going to do some questions in English first for all, for both of you, and then I think you maybe will be free for leave the table if Ramon and Kiko agree. Okay, please, Ramon, do you have any questions?
Yes, I have a question for Dr. Chapo. You recommend us during your talk about not use flow diverters in some kind of MCA aneurysm or serpentine aneurysm, for example. My perception is nowadays we are using a lot of flow diverters in parophthalmic aneurysms. Actually, I am concerned about the giant ones. I think most of these cases are diseases of the vessels, or of all the vessel. I don't know what do you think about that, but I think it's all the vessel that it's bad. No. My question is, what do you think about the flow diverters in these aneurysms, the parophthalmic giant ones? I have seen some too late growing years after in 2 cases. Maybe we might follow up very close this patient. MMT post-treatment is good. I don't know. And another question is, what do you think about the follow-up of this big or GN aneurysm treated with flow diverters? How do you do this follow-up?
So the larger the aneurysm, the more endovascular treatment is coming into trouble. Still, the amount of those aneurysms where the treatment is simple and good is still very high. I'm not the one you heard who is the most enthusiastic on flow diverters. I think that parophthalmic aneurysms are usually not the complicated ones, and in most situations the results are good, but indeed the giants that are unthrombosed, when they start to thrombose, there is a potential risk of bleeding. The other thing is, in some situations, the aneurysm, the ceiling is not properly achieved, and there is some further growth. There may be some technical reasons for this. Is just one flow diverter enough? How well is the stent placed? Treatment is easy in the small aneurysms because there is a lot of artery and material just placed in the artery. If there is a more vessel wall to construct, what you said as vessel wall disease, then the stent will be more in limitation of what can be done. So it's shifting into direction of, I would say, bypass.
Yeah. Okay. And follow up. What kind of follow up are doing now in the treatment of flow diverters? You do an arteriography 1 year after.
Follow up once, no MR. I mean, one angio is done because you want to know how the artery is. So to make at some point a control through DSA makes sense, but only one. And MR is being done. And once you have one MR that shows that the aneurysm is shrinking, then you won, then there is no flow. If the aneurysm is growing, obviously it's not good. It's not that frequent, but this may occur, and this is a limitation.
Yeah. So if you recommend, if the aneurysm is not shrinking, and if the aneurysm is maintained the same at the same volume, maybe we have to follow up during the following 5 or.
I think it's super difficult to recognize if an aneurysm, which is a giant aneurysm, has a change in size. If you just look at the picture, how to recognize if it's 27 or 28, and the change in 1 millimeter is a lot of change in the volume. So for this, there are some tools that are superimposition of pictures, and when you play with the mouse, you can see quite clearly whether there is a change. And the significance is much more important than the little millimeter that you see more or less. But it's difficult, and if it's difficult, it's not done very often, which is not ideal.
Okay, thank you very much.
Thank you very much, Professor Chapeau. Is there any question for Professor Chapeau? Okay, thank you very much, Rene. I want to thank Peter. Your presentation is very interesting. I want to thank you also your reference to Professor Smith, and we'll be waiting for the outcome of the CRAB study. But do you think that will be again a place for STA bypasses as was before the first study, or will be a difficult surgery or a few numbers of surgeries that will be done? Do you think that again will be a higher number of surgeries like that?
So Luis, I don't know. So what we decided to do is to perform our study ourselves in analogy to the BRED study, where one center decided with a high caseload to go ahead and make a pilot study to have whether
there is no sound.
No.
Do you hear me now?
Yeah.
Can you hear me? Yeah.
Yeah.
So so we will see whether our study as a pilot study will help us to better understand whether there's a chance to reverse it. I think the main point is whether we can separate the stroke prevention from the perioperative risk. For example, in the Moya Jet study, where bypass was performed to prevent hemorrhage in Moya patients, the same was done. So the perioperative stroke risk goes into the risk of the surgery, similar as when you perform a spine surgery. You tell your patient 10% risk of radiculopathy, and the outcome is different from the risk. So that's what we are going to do now in number one, to prove that the bypass can prevent the stroke, and number two, to have an idea without any bias about the complication rate. And then I'm confident that we will be able to change the field. I think all these studies, whether it's Aruba, whether it's COS, have simply been performed by neurologists that were aiming to show that maybe surgery is inferior or not superior. And now I think we have it in our hand to do it ourselves.
Thank you very much. Very interesting.
Yeah.
Is there any question more? Okay, I think that we have here excellent surgeons, because all of you are excellent surgeons. And I want to do a question for you with reference with the first table of this morning that was about hybrid surgeons. which is your personal opinion about a surgeon that could that is able to always perform surgeries by endovascular surgery and by openings or by open surgery? Do you think that this is a very good idea, or it is better to be focused on open surgery or endovascular surgery? For example, Peter, what is your opinion, and then Rene?
So I'm observing the scene in the US, and initially I was a little bit hesitant to recommend the hybrid solution, because each of these surgeons will shift more into the endovascular or more into the surgical direction. And I was convinced that we need two persons that are specializing in the field. However, I feel that neurosurgeons should have the possibility to have an entry into endovascular therapies. I think this should be done in an interdisciplinary setting, for example, in stroke teams. And I will not learn it anymore, but I think that our young residents are interested in endovascular treatments. I think they will be better surgeons if they are experienced with endovascular treatment. They might not reach the top notch as René is, obviously, but they can be a help in the daily treatment of endovascular cases. And if they are interested, then they become either hybrids or they can specialize on another neurosurgical specialty in addition.
Thank you, Rene.
Okay, it's an interesting point to discuss. Obviously, it's possible to do both. I still believe that if you want to push different aspects, I mean, if you have the chance to do both, as soon you're facing a difficulty, you will switch from one part to the other one, and it will be less, it will be more difficult to be able to push your technique and to develop things. I still believe that both belong inside a same department. Treating a patient without seeing him before, after, taking care of him makes no sense. So both are, let's call them clinical or surgical specialties. However, it should not be like this, that if someone is not a good open surgeon and he wants to do surgery and needs to find a place, then he'll be pushed to some other things that are less demanding, or that could be considered as less demanding, such as I don't know, endoscopy or endovascular or stimulation or whatever. So whenever you want to have something developed, it needs time to be learned. And in the end, within the same department, all our specialties move into subspecialization, and that's cutting and dissecting is quite different than catheterizing and feeling the tension on the catheter. But I think that both should be within a same unit or department, however you call it.
Thank you very much. And Kiko, what do you think?
I partially agree with both of them. Of course, I fully agree with Peter that the first thing for our residents is to learn endovascular. It's the key. It's key, because when I came to neurosurgery as a resident, I was very disappointed that the only ones knowing the embryology of the vascular of the cerebral vasculature, the really anatomy, were the endovascular guys. I think all residents should be trained in endovascular. But I fully agree with Dr. Chapot that to realize in one field, you should devote to one field. I couldn't. I wonder if I would be able to make the right decision on a Friday afternoon with a paraclinic, for example, or things like that. I think we have to have both options, full experts in that field, but I think we need a common stem for training the young guys, and then they will make up their minds. I think this is the key thing.
Thank you very much, Kiko. Ramon, do you want to say something?
Yeah, I think also, as say Peter Vaskowski, that the option should be there for the new new residents that want to do that, and it's difficult to know really how it will be the future. But as many new treatments in endovascular treatments as doing nowadays, I think most surgeons will enter in this kind of treatment. At least is we are treating the same pathology. So as is a different technique, at the end, the essence of the pathology is the same. So I think in the future it will be more and more neurosurgeons doing endovascular procedures.
Hybrid surgeons. Okay. And Kiko, a question for you. Do you think that in those cases that you show us, that very impressive cases, could change your mind if you have more, or do you have an easy access for endovascular surgeons, or you can change your mind in paraclinoid aneurysm, or do you think that maybe those aneurysms that you operate are always to be operated on, and there is no place for endovascular?
Most of the cases I showed you, I think, of course, in ICA aneurysms in paraclinoid, endovascular is key now. In many options, especially in small ones, and many situations, a flow diverted is our first option, not to say cavernous, things like that. But I told you that in situ segment, we consider two parameters very important. One is vision, and then the pituitary function. And we can bring something for the patient. In these two situations, we try to operate. And I feel that the situation is the other way around. In many places with great masters like René Chapot, I don't know, but you might not have the option of a good surgeon in some cases. So we have both, of course. Endovascular is growing, we see that, and we let that to be in our service. But we receive a lot of cases. There are cases for everyone, and we discuss the cases. And one point is that we, in urgent cases, in rupture cases, we try to solve the situation in the first 24 hours. And now, the situation in the vascular in Spain is that we are collecting more cases, but especially ischemia cases, stroke patients. And sometimes it's like a nightmare. Maybe one of these cases enter one morning and they did the night before 3 strokes. We have to consider the future and we have to organize. But surgery, believe me, is still a reliable option.
Very complete. Okay, Ramón, si quieres, el tiempo apremia.
Yes. I had also a question about Dr. Lawton, but I want to ask all of you. I think it's about AVMs. I think it's another thing that we thought is during this talk. What do you think? We did in Special Martyr 3 AVMs endovascular pre-embolization before the surgery. What do you think about it's the gold standard nowadays in your hospitals? Do you use it? Do you select the patients? What do you think about that? Please, Dr. René Chapot, what do you think about the pre-embolization?
I think that embolization of AVM goes from terrible to very good. AVM is a rare disease, so there is no way to practice just like strokes that come every day, everywhere. And that transarterial embolization, which is the usual way to proceed, did not bring all the expectations. The rate of patients being cured is not good. The rate of complications is too high, and with too many problems related to this. And when complications, then terrible complications, because bleeding after embolization are worse than regular bleeding, or maybe worse. On the other hand, development of transvenous embolization opens the door to treat the most difficult AVMs, which means the deep vein is much easier to access than a cortical vein from the sinus. And we can downgrade AVMs that are Spector 4 or 5 to significantly lower, or cure by doing stage venous embolization. And because of this, this is a game changer, but it's still very new and not much diffused, with one problem. Getting through the vein has the advantage that if you go through the vein, you have very often the best way to access to the shunts. That's a positive. The negative is if you occlude the vein, under embolization is not possible. And under embolization is done very often in arterial embolization. And if you leave just one shunt open that you will better see. So cortical AVMs are, I think, usually better to be treated by surgery, because you will see all arteries that become very difficult to see endovascular by getting through the vein. But that may be occluded. So all the mixed features that are superficial with a deep drainage, it's possible to occlude all the deep part, making the AVM much better to treat. And I think that this is a very suitable and, without any doubt, a future for this kind of disease.
Okay. Dr. González Llanos. Doctor González Llanos.
Yo creo que...
Sí.
¿Me oyes?
Sí.
No, que, bueno, deberíamos ir concluyendo, ¿no? Si quieres comentar un poco qué piensas de... Y el doctor Luis Ley igual, qué piensa un poco de la embolización en las Spelder Martyr 3 de forma preoperatoria.
I think embolization, I feel agree with the great matter Dr. Chapot said. I think in grade 3, you have to select each case and see what is the problem. Maybe is the size, or is the location and the drainage. And I think embolization in many of our cases, it's always valuable in the treatment.
I think that everything is said. I think that grade 3 AVMs are a thing that we can be talking about many hours, and I think it's very late and we have to finish. So thank you very much all.
Okay.
And I think it's a very good table, and I hope see you personally, not virtually, soon. Thank you very much all.
Okay.
Bye.
Bye-bye.
Bye.